Okay, Mark, I see your screen. Everything looks terrific. Let's take a small pause and then I will introduce you. Well, welcome everybody to Optometric Education Consultants National Webinar Series, Tuesday night edition. Our presentation is by Dr. Mark Dunbar. The pressure is on, managing challenging cases in glaucoma. I am particularly looking forward to this presentation. Dr. Dunbar has been a member of the optometric staff at the University of Miami's Bascom Palmer Eye Institute for over 30 years and currently serves as the Director of Optometric Services. He's also co-chairman of the Conference Advisory for Vision Expo. And for those of you that may not know, Bascom Palmer perennially ranks about the #1 eye hospital in the United States. Dr. Dunbar is a fellow of the American Academy of Optometry and a founding member of both the Optometric Glaucoma Society and the Optometric Retina Society. And that's some ground that Dr. Dunbar and I have plowed across together for many years and many years ago. He also serves on the editorial boards for Review of Optometry, where he writes the monthly column Retina Quiz, which must be going on over 20 years. Exactly. Dr. Dunbar has been a friend to optometry, a leader in the profession. I think one of the foremost educators, a close and good personal friend of mine. So with it, I think it's all our privilege to see and hear Dr. Mark Dunbar. Mark, please take it away.
Well, thank you, Joe. As you know, it's great to be invited. I'm always impressed when you guys put these programs on, and the amount of people that join in is really staggering. So it is an honor. As you know, I've done a few of these programs for you. I always have a good time. Let's hope that the technology works tonight. Sometimes it does, sometimes it doesn't, but it's fun when we get some audience response and interaction, especially when it comes to glaucoma. As you said, the pressure's on, managing challenging cases in glaucoma. I'm going to give Joe a lot of credit for this because he was really the inspiration for some of this. When he was at Nova, Joe had asked me to do some lectures periodically. And I remember there was one that had to do with which pressure in glaucoma is most important. And at the time we were looking at blood pressure and perfusion pressure, and of course, eye pressure. And that really kind of launched the basis or the background of this lecture. And that's what it is. We're going to build it around cases and hopefully, have some good discussion as we go along. See if I can advance. There we go. Financial disclosures. Again, I don't think we're talking about anything that's proprietary or trying to sell you anything or tell you which OCT camera or anything to buy. Let me just say, this is my full disclosure. Nothing I say in this lecture will have been an original thought. I have shamelessly copied and pillaged almost every thought or concept discussed in this talk, and I will give credit as we go along, and I'm not ashamed to say that nothing I said will have been an original thought in this talk. We do want to do poll everywhere, and let's see if it works. So I'm going to have you, if you have a phone, put your phone up, and you'll get on your browser, it'll pop up, and it'll tell you that you're active. And I'm going to wait a few seconds. So everybody, if you have a camera, put it on, and I can see I spelt poll everywhere-y wrong. It should be poll everywhere. But join in. We can have some discussion based on some of the questions. And again, it's just meant to be fun and generate discussion. I'll give everybody a few seconds to do that. Bring your phone out, use the QR code, and get on. The other way you can do it, in your text box, you're going to type 37607 to the number, and then type Mark Dunbar 514. That's the other way you can join into the poll everywhere. And it'll say, welcome to, can't remember what it says, but something along those lines. You're gonna welcome, and then you'll be in. Let me go back just to make sure you got your phone. We got poll everywhere with your QR code. You just hold your camera up and it'll capture the image and send you to a link on your browser, and it'll say that you've joined. Any comments, Joe? Everybody seemed to got it. I don't want to.
I think so.
Or as I said, you can type in 37607 And in the message, Mark Dunbar, 514. And so here's my prediction. This is the premise, at least for a portion of this talk. Do you believe there will be a treatment for glaucoma that doesn't involve taking a pill, a drop, having a laser, or a surgery? And that will be the question. Do you believe there will be a treatment for glaucoma that doesn't involve taking a drop, pill, laser, or surgery? And is that showing up, Joe? On your all's computer?
No responses yet.
Okay, so it may be, hang on, because it shows up on mine. And we have, and sometimes it depends on how you, let me try to get out of this. We'll go back and I'll give you the results here. Can I do, depends on how we.
Looks like I get a message that says poll is down for maintenance.
No, it's up, but I'm
Okay.
trying to, how do we, visual settings, no, how do we, let me see if I can. So what it's 2/3, 63% say yes, and about a third of you say no. But sometimes when it's hooked to an LCD, it won't show, but you have to kind of set it differently. And I was wondering, we don't have an LCD, so no.
So you'll just have to tell us what the results are if you can
Yeah.
see that.
So 2/3 of you will say yes, and as we go along, we'll kind of see how that kind of shakes out. And then our next question: do you have an OCT? Did that pop up? So it's interesting. When we've done this in the past over the years, Joe, it started 30-40% of the attendees would have OCTs, and then over the last probably couple of years, that number has gone up to almost
broccoli and some chicken and some barbecue sauce.
over 70%. But tonight we're about 60%. We're 55, 56 have OCTs, and about 44% do not have OCTs. All right. So I think we understand, right? The higher the intraocular pressure, the greater the risk of acquiring glaucomatous damage, and the greater the risk for progression. I think we understand that there's factors other than IOP that contribute to optic nerve damage and really determines an individual's susceptibility to harm from intraocular pressure. The problem is at this moment, there's really no effective treatment for glaucoma beyond lowering intraocular pressure. It's kind of the idea, if you're a hammer, everything looks like a nail, right? And so when we see glaucoma, the one thing that we have to measure is intraocular pressure, and the one kind of effective treatment that we have is lowering the intraocular pressure. But I think we all recognize that there's probably, other factors besides IOP that contribute to glaucomatous optic nerve damage. Blood pressure. Interestingly, when we talk to our patients about glaucoma and we talk about eye pressure, they always equate it to blood pressure. And they talk about, well, as my blood pressure is high. And so we always say, well, no, it really has nothing to do with your blood pressure. But the fact is it may have a little bit to do with blood pressure, and not that it's actually high blood pressure, but perhaps low blood pressure, right? And that kind of feeds into the idea of when you have low blood pressure, that really affects the blood flow into the optic nerve and into the eye. And when you have reduced blood flow, that ultimately affects the perfusion pressure. And so these two things really, there's been a lot of discussion, a lot of papers in the literature about the effect of low blood pressure and low perfusion pressure. Something that I think is really very interesting is really what about, either intracranial pressure or the same thing being cerebral spinal fluid pressure, and how does that relate to a patient's susceptibility of having glaucoma or maybe even progression in glaucoma. And that's something we'll kind of address as we go along. And so let's kind of lead off with the case here, right? Here's an 80-year-old white female who presented for, we'll just call it an annual eye exam. She'd never been to Bascom Palmer. I had never seen her. She had seen a community ophthalmologist and had been doing pretty well. She had cataract surgery. This is probably about 2018, give or take. And so she had cataract surgery a year earlier. Everything went pretty well. She was relatively happy with her vision. Mom had glaucoma, used drops that she remembers. Really generally does not wear glasses except maybe for driving. And so, yeah, this is October 2017. You can see it, really nothing too unremarkable. Her pressures are 15. She corrects with a little astigmatic correction to 20/20. And so everything's cruising along well until you dilate her. And as you can see in the right eye, she's got a disc hemorrhage. And so again, you look, she's got some peripapillar atrophy. You know, the shape of the nerve is a little bit vertical, and that goes along with the shape of the cup, which may be vertically long. And again, this is a two-dimensional photograph, but again, I think the presence of a disc hemorrhage and maybe inferior thinning certainly suggestive of glaucoma. The left eye doesn't look as bad. You know, I would have called the cup in the right eye maybe 0.5 horizontal by maybe 6 or 6.5 vertical. The left eye looks a little more round, but perhaps that inferior temporal slope. It looks like she probably was a myope in the past before she had cataract surgery. Again, the left eye maybe a little posterior staphyloma, and you can see the presence of peripapillary atrophy. And of course, we do what we all do now in this time. Now that we have OCTs and visual fields and so on, we do an OCT, and as you can see, this is the serous. And you look on the kind of the deviation map, that area where we saw this Grant's hemorrhage, if you will, shows thinning, but there's also some thinning in the left eye. I also tend to look, you know, at the thickness maps, and you can see generally overall, this is a little thin. You can see that it's a good scan. Then when we look at the quadrants and clock hours, it's, you know, no red, certainly suggestive, but, you know, I think the combination of the disc hemorrhage, what we see on the deviation map is really, I think, pretty suggestive of glaucoma. Again, you know, you look at some of these average thicknesses, disc area, average cup to disc ratio, and so on. I look at it, the totality of it, you know, I think is, again, mainly the thickness map and the deviation map really kind of suggests that she's a glaucoma suspect. Here's her ganglion cell complex. And this kind of squeegee cutter pattern really, to me, is really very suggestive. I don't want to say pathognomonic, but anytime, you know, when you're doing a GCC and thinking about glaucoma, that almost X-Acto knife squeegee cutter appearance is really very suggestive. So, you know, the presence of the disc hemorrhage, what we see on the OCT, RNFL, and then the ganglion cell complex, I think really is suggestive of that she has glaucoma. And so again, the question is this low or normal tension glaucoma? And you know, whether that really matters or not, I don't really know. I think really the more important question is if this lady is sitting in your chair, you know, would you treat her on this visit? Would you begin treating her? And again, I think we've got another poll everywhere. The answer is yes, I would. No, I wouldn't. Or would you refer her to an ophthalmologist for those who don't treat? And this is really an interesting one, right? So we've got about 50% of the people say no, they wouldn't treat. About a third or 35% say yes, they would. And then there's about 14 or 15% of people say they would refer it to an ophthalmologist. And so, you know, I don't think the question is whether she has glaucoma or not. I believe she does. I think the evidence is pretty strong that she does. You know, I think there's no doubt she needs to be treated. The question is, do you need to treat her now? And I always like to get at least a couple baseline pressure readings before I will begin treatment. And you go, I'm of the adage, I think you have time. Doug Anderson always used to say, Doug is a glaucoma specialist at Bascom Palmer. He's retired. He's considered at the time a kind of a visual field expert. He had a passion for normal tension glaucoma, but Doug would always say, never make a decision based on one IOP reading or one visual field. And I believe that for the most part. So here's a lady who the first time we see her, She's got a disc hemorrhage and an abnormal OCT. I think, as I said, there's no doubt she has glaucoma. The question is, and I do think she needs to be treated, and we can debate in normal tension glaucoma when you treat or when you don't treat. But I like to get a little more information before I treat. I want to get another pressure. And again, no question, we got to bring her back. We haven't done a visual field. We do all our visual fields undilated. So when I bring her back, I'm going to get a visual field and I'll get a chance to get another intraocular pressure reading. 50% of you essentially said, no, you wouldn't treat. About 35% said you would treat on this visit. And about 16% said that you would refer this patient to an ophthalmologist. As I said, I would bring the patient back, and you can see what my impression and plan was. I said it was probable normal tension glaucoma. You could kind of describe everything that's happening. And I was going to bring her back in 1 or 2 weeks to get a visual field and another intraocular pressure measurement. And then at that visit, I would probably start treatment. And of course, we gave her a prescription for glasses.
Mark, a question
Yep.
came in. It's like, wouldn't you look for some progression first?
So that's a great question, because that's really the debate in normal tension glaucoma. The suggestion, from the normal tension glaucoma treatment study that was done in the 1980s and 90s said that, unless there's advanced field loss, the recommendation was not to treat, because 50% of patients, both in the treated group and in the non-treated group, 50% of patients never progressed. So the idea was, if it's either early glaucoma or kind of borderline or moderate glaucoma, wait to treat to determine, is this a patient who's going to be one of those progressors, or this going to be a patient who is going to be stable and maybe not needs treatment. And so part of that is really predicated on the visual field, which I haven't shown you. So the idea, if it's early or mild glaucoma, I think there's room to wait. If it's obviously advanced or visual threatening glaucoma, you treat. And again, that's predicated on the normal tension glaucoma treatment study. So it's a great question. It's certainly an appropriate question. Here's her visual field. Left eye, again, first time test, fairly reliable when you look at some of the parameters. Some noise down here, but I would kind of call this, I always look at the pattern deviation as kind of the critical area I look at. So this is the left eye, the one that didn't have the disc hemorrhage. You can kind of see she's got what I would call a nasal step. This right eye looks a little worse, right? And consistent with what we saw on the OCT. I would call this almost a superior arcuate with a superior nasal step. I don't know what this represents. For the first time, as we're looking at it, I'm thinking, could this be a quadrant neurologic defect? Doesn't really respect the midline, but point is, and I think I'll kind of let you look side by side in this right eye, particularly, I think it fits very nicely. And so, based on that alone, and again, the totality of the picture, I decided that I was going to treat her. And so I put her on latanoprost. Again, pressure 14, 15, what are you shooting for? And I would say just any lowering of intraocular pressure would be acceptable, right? If we can get her 12 or 13, the hope is that's maybe good enough. Is it a prostaglandin the best choice? We know it's the most commonly used choice. I think they're powerful enough. And again, the idea, I'm bringing her back in 3 months. Would you wait and bring her back a month? Is 3 months too long a period of time? And again, we can kind of debate some of the nuances of when you want to bring a patient back. I get to a point, I hate bringing patients back over and over. So I feel like the prostaglandins are pretty potent. I feel pretty confident in it. So this was an idea. I'll bring her back in 3 months. And that's what I did.
Hey, Mark,
One
question that came through is, what if there had been no disc hemorrhage there?
If there had been no disc hemorrhage, I probably would have missed the glaucoma. The nerve is certainly suggestive, and a pressure of 15, you look at it, peripapillary atrophy. I might have looked at it. Those are the tough ones. I could have very easily not have recognized that she had inferior thinning, and again, it just depends on how much, right? I don't remember looking on the photograph two-dimensionally, but I could have easily bypassed it. The left one looked more round. The right one certainly suggestive, but again, I could see myself maybe thinking, cataract surgery looks pretty good. She's 20/20 and maybe, not recognizing it. So this is a kind of an algorithm that's developed by Peter Chang in his book, Clinical Decisions in Glaucoma. This was a second edition to a book that maybe some of you are familiar with. This was a book that was written in the 90s by Hodap, Anderson, and Parrish. And it was a great book at the time. It was very cookbooky in terms of how to manage and recognize and treat glaucoma. Unfortunately, like many textbooks, they rapidly become out of date. And so Peter did an update, including some of the newer visual field algorithms, some of the information on OCT that we didn't have back then, and other things. It's just a great, great book. You can order it. You can, I think, get it for free. There's some sites, especially if you're, I know the ophthalmology residents can. I'm not sure about optometry residents. You can order it from Amazon. If you search around, you can probably get it, or at least get a PDF. But this is one of Peter's algorithms, right? And it's really predicated on the question that was already brought up, right? So is the pre-treatment IOP above 21? And if it is above 21, that's not really considered, quote, normal tension glaucoma. If it's lower than 21, and so no, it's not higher, it's no, is the defect moderate or severe? If it's not moderate or severe, then the question is fixation threatened? And if the answer is no, you have room to observe the patient and determine if there's progression. If, on the other hand, the defect is moderate or severe, or if fixation is threatened, then that's a patient you should treat. And again, from the normal tension glaucoma treatment study, they chose a 20% reduction in IOP, and that's really what you shoot for. And again, there was nothing magic about a 20%. They just decided that would be kind of, with the available treatments that were available in the 1980s and 90s, 20% was a reasonable achievement. And again, the question they wanted to ask was, is lowering of pressure in normal tension glaucoma beneficial? Yes or no? And then what is natural history data? And so that's kind of the algorithm. I think it's pretty good. And we may have a couple more in here as we go along.
Mark, another question came in about age and saying, wasn't she 80 already? And is that a person who really needs to be treated?
Yep. Great question.
There?
Yeah. So I think you're right. It is a great question. And it really, part of this evidence-based medicine discussion that sometimes I have, where really it's based on the patient in the chair. Is it in the best interest of them being treated? What is her risk of blindness at 80? I think, yeah. I'm not sure, again, given the amount of visual field loss, that I would not treat her, but I think it's a fair question to ask. And I think given the fact that a prostaglandin is fairly simple, right? It's easy to use, and we know it's pretty effective. It's low impact. And so I don't think anybody would suggest not treating her other than this normal tension glaucoma treatment study. But again, the idea was I would treat her just because it's easy. Now, if the question was, gosh, we're not at target, would we do a trab on her? I think if you're looking at an aggressive form of treatment, I think then certainly looking at an 80-year-old and asking the question, what is her risk of going blindness in her lifetime? And that's ultimately the fundamental question that we all try to ask and answer when we're looking at our patients, a 40, 50-year-old compared to an 80 or 90-year-old. Do we really want to take her to the operating room? And I think, yeah, in that situation, you think twice about that in an 80-year-old. But, again, I think it's pretty easy to put her on a prostaglandin and at least do your best in a simple, non-invasive manner to lower the intraocular pressure.
Mark, real quick I'm going to hijack somebody's story.
I love that. Go ahead.
You know Tony Riolini, correct?
Yeah, of course. Yeah.
Tony Riolini is a glaucoma surgeon out of University of West Virginia who admits to doing 2 miserable years of private practice in Arkansas. And he had a patient there who was an ocular hypertensive, and she was 93 years old. And he had the discussion about high pressure, risk of glaucoma. But he said, I'm not going to treat you. I don't think that you need it, because, implying that she's 93. And her response was, but my mother has glaucoma. Not had, has glaucoma. He found out she's 93. Her mother is still alive. He said, yeah, I'm going to put you on a prostaglandin.
Yeah. And I'll tell you, she's a spry 80-year-old. So I could definitely see at least another 10 or 15 years in her. Again, the question is it how rapidly progressive is it? Those are the questions, again, only over time do you know the answer to. And so I did, she was pretty good about coming in, and I'm going to fast forward to about a year later, right? And now you look at her, and again, we've got a pressure of 12, And not only does she have another disc hemorrhage in the right eye, so a new disc hemorrhage, but she also now has a disc hemorrhage in the left eye. So how about that, right? And really the fundamental question that we're going to kind of dive into here in a few minutes is, how is it that a patient with a pressure of 12 can continue to progress? And it really begs the question whether what other factors besides pressure kind of contribute to this. And I wanted to kind of show you, this was the 2017, and it's different. These disc hemorrhages go away in 2 or 3 months. And so here we are literally a year later. So it's not just the same disc hemorrhage, it's kind of slowly dragging on. This is a new one in the exact same area. And yeah, now you look at the left eye. And here's her OCT on that October visit. And again, we're looking at some of the parameters here. Inferior, that's not a lot of change. Superior, maybe 10, 15 microns, not too much. You look at our kind of algorithm here longitudinally. Again, 2 or 3 OCTs I don't think are quite enough to really look at that. It's suggestive. Temporally is really not an area, but again, the other areas look pretty good. Here's the difficulty, right? You look on the 220, look at the blues here, 2017 inferiorly, and here we are, the 2018, and if anything, she looks a little bit better, right? And yet in the left eye, you can look and clearly the left eye is a little bit worse, especially in that inferior temporal area where you see really a 20 plus micron change. We tend to cherry pick, right? If it's better, we kind of discount it, but if it's worse, you say, aha, this really represents progression.
Mark, did you have a pachymetry on that person? Somebody asked.
I did, and I want to say average. I did. Can't remember if it was in there or not. Usually it automatic displays in our electronic health record, and I'm not sure, but she wasn't thin by any means. I want to say 540, 550. And so, so what do you do now, right? So pressures of 12, she's on a prostaglandin. Do you simply observe her? Come back in 3 or 4 months? Would you add a second medication? Would you add a combination medication? Or would you refer her for an SLT? What do you do, Joe? Pressure of 12 and a new disc hemorrhage. Do you just kind of ride it out, or do you feel like you need to do something?
Well, if I had a patient who started off at, let's say, 28 and came down to 19 on a prostaglandin, which is very reasonable. I know it's not quite the same thing. And then they develop disc hemorrhages. That tells me that the lamina is changing. So there's a mechanical force going on. I can add another pressure and significantly lower that 19 further. Do something.
Correct.
But with a pressure of 12, there's not much you can do. I'm going to sit and ride that one out. And if a person's truly getting worse at a pressure of 12 or 11 or 10, they're more likely to lose vision from the treatment than they are from the disease.
Yeah. So,
I mean, if the field's staying the same, we worry about disc hemorrhages. We worry about disc changes, but if the field doesn't change, there's really no issue for the patient.
So 46% of you said you took Joe's, 47% Joe's approach. A little under half said you would simply observe. Little under 20% said you would add a second medication. A few of you said a combination. A quarter of you, 24%, said you would refer for an SLT. And here's the beauty of this, right? There isn't a wrong answer. I think whether it's not a corneal ulcer or a retinal detachment where you got to do something. It's one of those things where, you can observe, right? Watch her, pressure 12. How low can you get? Are you able to get her any lower? Certainly not wrong to add a second medication. In fact, that's what I did. I added a second medication. I didn't do a combination, and again, wouldn't be wrong to do an SLT, remove the burden of having to take a drop. I guess you could wonder, would you get any more with an SLT? But, all fair answers. A few quick thoughts on disc hemorrhages, right? So, we see this, I don't want to say routinely, but we see it fairly often enough if you've got a geriatric glaucoma population. And the fact is, the one on the right, nobody misses. The one on the left, well, our right, our left, right? The subtle one in our right-hand view, that could easily get missed. And so I always like to ask this question, right? In the ocular hypertensive treatment study, what percentage of disc hemorrhages were missed by the doctor? Was it 24%? Was it 44%? Was it, I got to go back because I can't see, 64% or 84%? What percentages of disc hemorrhages were missed in the ocular hypertensive treatment study? And so remember, the idea was, every patient in the OAT study had a picture taken. And of course, the doctor also evaluated them. The doctor, of course, would look clinically, and then the reading center would also look. And so, Joe, I'm pretty sure you know the answer to this question, right? Does this always kind of amuse you?
It does, until it happens to me. That's not so amusing.
So the right answer is 84% of the clinicians missed the disc hemorrhage, but the reading center was able to pick it up. Not 44, not 24, 84% of the time, the disc hemorrhage was missed by the clinician and seen. And again, it goes back to, this one, right? Nobody misses this one. This one kind of smacks you on the head, but you look at this one, and this is a 2x magnification view. You can easily see where this could have been missed by almost anybody. And so, yeah, this was from the paper Down Good Ends in December 2006 in ophthalmology. Disc hemorrhage were detected in 128 eyes, 21 cases detected by both the doctor and the photos, 107, 84% were detected only by a review of the photography. And again, this just goes to show that if you had a disc hemorrhage, it puts you at almost double or 3 times, they said 6-fold increased risk of going on to develop glaucoma. That was at 5 years. At 10 years, that increased risk went up to over 25%, versus if you didn't have a disc hemorrhage, it was only about 12%. And that's kind of the paper there, right? And the obvious one, older age, larger cup, higher intraocular pressure, thinner cornea, all those things were risk factors for having progression in the OAT study. This is a Doug Anderson one as well. And I'll just throw this out there, right? So remember, these were people who didn't have glaucoma, but had increased elevated intraocular pressure that at baseline had normal visual fields. So what would happen if they had an abnormal visual field, right? Is that the trigger for, you've converted from ocular hypertension to glaucoma? Well, in that scenario, when they repeated the visual field, 86% of the time, the patient went back to a normal visual field, and only in 14% was the abnormal field confirmed. And again, it goes back to my Doug Anderson statement that I don't always live by, but I try to live by. Never make a decision based on one intraocular pressure reading or one abnormal visual field. When in doubt, especially when pressure is confirmed, bring it back, test it again. Maybe it'll go back to that baseline, or repeat the visual field, and maybe it goes back to what that normal is. And so, again, getting back to our patient, again, the bigger question is how that she can continue to progress or develop a disc hemorrhage with a pressure of 12. And so what are the factors that really predispose a lady like this to progression? And these were kind of some of the things that we talked about, right? Blood pressure, reduced ocular blood flow, and intraocular pressure. And so, yeah, where does blood pressure fit in? And again, this has been kind of banded around by the glaucoma specialists for years and years. A few papers back in the 1990s by Hay, Ray, Drance, and others first raised that kind of important issue of not systemic hypertension, but hypotension. And that combination of low blood pressure or nocturnal blood pressure dips. And of course, what often happens when you're sleeping, especially right before waking hours, you have low blood pressure, but yet the intraocular pressure tends to be the highest right before those hours of waking. So it's, maybe that combination of low, bottoming out of the blood pressure, hypotension with increased intraocular pressure that really maybe sets the stage during these critical times in the morning that patients develop damage to the optic nerve as a result of a reduced blood flow to the optic nerve. So again, essentially saying the same thing, BP is lowest at night, IOP is highest, and that combination of increased IOP and low blood pressure really results in this decline or decrease in the ocular perfusion pressure. And so what is ocular perfusion pressure? It's the relative pressure at which the blood enters the eye. It's defined as the arterial the ocular arterial pressure minus the intraocular pressure, so that delicate balance between IOP and blood pressure. There is a kind of fancy formula that, probably somebody thought of, and maybe that's really more the exact one. But a lot of people do just in the chair, they'll take the diastolic blood pressure minus the intraocular pressure, and that in a rough estimate becomes the ocular perfusion pressure. And again, this has really been studied in a lot of clinical trials and population-based studies, the Baltimore Eye Survey, the Proyecto VER study, the Los Angeles Latino Eye Study, the Barbados Eye Studies. These are all kind of cross-sectional population-based studies, not only looking at glaucoma, but they look at diabetes and macular degeneration, a number of things. And so, but again, when you look at, that scenario of low ocular perfusion pressure in developing glaucoma, you can see in all these studies, there's an increased risk of glaucoma. This was, again, another way of looking at it. And in a couple of these studies, they defined ocular perfusion pressure of anywhere less than 50 to 55. One of them, the studies, this was the Egna-Newmark study. I'm not familiar with that one, but they defined it as less than 68. But that, 50 to 55 is, I think, a kind of a good estimate. And so, you look at my little old lady who's got a pressure of 12. She's thin, she's frail, and you wonder, does she fit this kind of scenario of low ocular perfusion pressure? This was a study out of New York, the low pressure glaucoma treatment study. And again, really almost the same thing. They talked about the fact that, we determined that lower mean ocular perfusion pressure during follow-up was significantly associated with visual field progression in our model. And this was not significantly affected by other covariates. So, the problem is, right, that perfusion pressure is really difficult to accurately measure. There's really no widely accepted consensus in which technique. The idea that you're measuring blood pressure in the brachial artery on your arm, and how does that correlate, or is there a direct relationship between that and really blood flow into the eye? And so I think it's a fair, question. I think it's fair to really wonder, it makes sense to me, right? You look at this, OCTA of really blood flow released to the superficial retina into the optic nerve. And of course, we'll look at what happens behind there a little bit. And so there's no question it is complex, and you got to believe that blood flow and perfusion pressure has got to play a part in this. But as I said, none of these methods used to estimate blood flow have been standardized or really externally validated in humans. And so, this is the slide, right? A complex arterial supply and an even more complex venous drainage system. And so which vascular network is most critical in the development of glaucoma? I think we've shown that OCT angiography, at least in diabetes and macular degeneration, is very helpful and critical. I'm not sure yet, where we are in glaucoma. I've done a number of lectures with Greg, and Greg uses his OCTA quite a bit, and he's got a number of cases where he will show nerve fiber layer defects, and really where the OCTA, again, kind of complements the other technologies in showing really the effect of ischemia and perfusion on the optic nerve. And so I think we recognize it's, clearly plays a role. It's a matter of time before the technologies get better and we have better ways, better algorithms, maybe developing normative databases and, and helping us really look at blood flow to the optic nerve and really what that means. And then kind of you think about, what about cerebral spinal fluid, and maybe is that not a better marker for change at the optic nerve, right? And you look at cerebral spinal fluid, and this is kind of what I'm highlighting here, and the fact that you look at, the close proximity to the optic nerve and the lamina cribosa, and it makes sense, right? Perhaps either low or high cerebral spinal fluid pressure may have this, maybe a better corollary. So again, the idea that the primary site of retinal ganglion cell insult is at the lamina cribosa, and you look at that close relationship anatomically between cerebrospinal fluid pressure and optic nerve, and maybe that becomes a better marker or a better algorithm. And so again, you look really back to the 1970s, a couple people looked at that. This is Valkov, who pointed out that cerebral spinal fluid pressure could pathogenetically be associated with glaucoma optic neuropathy. And a paper out of Russia in 1979, Yabolinsky postulated that abnormally low cerebral spinal fluid pressure on the optic nerve may play a role. These were barotraumatically induced optic nerve damage. But it really wasn't until 2008, and This is really where John Bradall comes in, and he's really done kind of the most in this area of really the relationship between cerebral spinal fluid pressure and glaucoma. And in one of his studies, I think he was either a resident or fellow at Mayo Clinic, really found that low cerebral spinal fluid was really kind of the critical aspect. And so you think about it, right? So Mayo Clinic has a great reputation around the world. He simply looked at the number of patients over a 10-year, 11-year period who had lumbar punctures, and that number being about 31,000, 32,000 people. And of those 32,000 people, he also looked at, well, what percentage of those had eye exams? And then of those, which percentage of people had glaucoma? And so again, of that 31,000, 28 people met the inclusion criteria for glaucoma. He looked at 49 controls. And essentially what he found was that cerebral spinal fluid pressure or intracranial pressure was significantly lower in patients with primary open-angle glaucoma compared to those who did not have glaucoma. And so that was his first study. Here's the second one that was published a year or two later. Remember, the first one had 38,000. This one had over 62,000 people. This was over a 20-year period. Again, 189 met the inclusion criteria of having a complete eye exam. And so he looked at POAG, normal tension glaucoma, and as well as ocular hypertension. And again, found this relationship that intracranial pressure was significantly lower in patients with POAG and normal tension glaucoma, and significantly higher, in fact, in people with ocular hypertension. Here's a third study. I think this is out of China, essentially doing the same thing, right? Patients, and again, not quite the large numbers, but 43 patients, open angle glaucoma. I can't remember how many people that, they looked at that had, lumbar punctures. But again, they found really the same thing in normal tension glaucoma. These people had lower cerebral spinal fluid. This is actually, I guess it was the cerebral spinal fluid. The next slide is translaminar pressure difference. But again, in the normal tension, you're looking at about 9.5 plus or minus 2 compared to the control group that had higher cerebral spinal fluid pressures. And then looking at the translaminar pressure difference, what we'll get to in a minute. But it's that the difference between the pressure inside of the eye and the cerebral spinal fluid pressure they defined as this translaminar pressure difference. And again, in a control group, in the normal population, that pressure difference is really very, very low, but yet in glaucoma, either normal tension or high pressure glaucoma, that translaminar pressure difference becomes much greater. And I know that's kind of sounding confusing, but let me kind of bring this all together. And let me kind of explain it this way. And again, I won't take credit for any of this. This is all kind of John Bradall's work. And I was sitting in a lecture in SECO 2 or 3 years ago, maybe 3 or 4 years ago, where John Bradall was actually giving this lecture. And I was literally mesmerized. I think it was one of the best lectures I ever heard. And it really kind of challenged my thinking. And it's what really kind of got me interested in this. And he kind of really asked the question, right? Well, what does a pressure of 16 really mean? And our conventional kind of wisdom we're thinking is, well, it means that what does it mean? Pressure of 16 means that the pressure inside the eye is 16. And the fact is that's really not the right answer, right? That when we measure a pressure of 16, it isn't that the pressure inside the eye is 16. In fact, it's really 776 millimeters of mercury. And the reason that is because you think about, at least at sea level, the atmospheric pressure around us is about 760. So if we're looking at somebody who's got a pressure of 16, take into account atmospheric pressure, the pressure inside the eye must be 16 millimeters of mercury higher than that 760. And again, it gives us a math problem, and that's really what a pressure of 16 is. And so what we're really looking at when we talk about what is IOP, it's really that transcorneal pressure, right? It's that pressure difference between what's happening inside the eye and what the atmospheric pressure is. And again, at sea level. And so again, John kind of gives this example, and he was on his honeymoon with his wife and he was diving. And if you have been deep in a pool or a snorkeler or a diver, you know that if you're 10, 15, 20, 30 feet in the ocean, you know that the atmospheric pressure increases exponentially. And so, the question was, well, what happens when I'm diving? The pressure gets so high, what happens inside the eye? And of course, the answer is that the eye is able to equilibrate. Oh God, almost need a drink on that one. Equilibrate, right? So it's able to kind of adapt to the pressure in it. And so again, this equilibrium, if you will, is maintained. And the same thing when you're at high altitudes, right? You have a low atmospheric pressure, and it's really the same thing. And so again, we kind of talk about glaucoma, and again, somebody who's got a pressure of 26, that transcorneal pressure difference being 26. And of course, what we do is, you put a patient on a glaucoma measuring drop, and yes, it lowers the intraocular pressure. And of course, it gets us back down to a pressure of 16. But here's the question, right? It goes back to the question that I asked earlier, right? We're measuring this transcorneal pressure, right? We put them on a prostaglandin or a combination drop, and we're measuring pressure on the front of the eye, but yet all the action is really occurring back here at the level of the optic nerve. And we know it works because we've had 80 years of treating glaucoma. We know that lowering the intraocular pressure makes a difference. But the fact is this the best surrogate? Is this the best marker for really knowing what happens in glaucoma? So yeah, how does the pressure here affect what's happening at the optic nerve? And so let's kind of marry all these three things together, right? So if you look at cerebral spinal fluid pressure in the normal situation, that translaminar pressure difference really is there's a minimal difference. That translaminar pressure difference is about 4 millimeters of mercury, right? And so in the normal state, there's minimal translaminar pressure difference. And what happens when you increase this difference, it alters that homeostatic balance, and it results in a pressure gradient difference at the lamina. And so this really almost becomes like a physics question, right? So if we think of high intraocular pressure in the presence of low cerebral spinal fluid pressure, I think we can see very nicely what happens in this situation, right? That's glaucoma. That's what we see all the time. High intracranial pressure, low cerebral spinal fluid pressure really sets the stage for somebody having glaucoma. And so, yes, right, we've got somebody who's got pressure at 25, maybe they've got low cerebral spinal fluid pressure. So you look at that translaminar pressure difference being great. We put them on a prostaglandin, we get that pressure down from 25 to maybe 13 or whatever it is. And so, yes, we lower the intraocular pressure, but we're also reducing or lowering that translaminar pressure difference, getting them down to 25 to 16. Now we're reducing the translaminar pressure difference. So hopefully you've been able to follow that, and that makes sense. Here's kind of the cool side of this, right? Anybody watch the movie or read the book by Jonathan Weir, The Martian, which
Yep.
I read the book, and which I loved, and I watched the movie. Were you going to say something, Joe?
No, I watched it.
Yeah. I think it's great, but all of a sudden, right, it really kind of generated this interest in putting a man on Mars, right? And prolonged space travel, and obviously it's a great idea, and it's exploring the yet unknown, but there's a problem with that, right? What is the problem with prolonged space travel? And it's called spaceflight associated neuroocular syndrome. Say that to yourself, SANS, spaceflight associated neuroocular syndrome. So what happens when astronauts or people are in space travel for a prolonged period of times where there's, in a sense, zero gravity? 60% of astronauts suffer ocular problems related to prolonged space travel. So again, globe flattening, hyperopic shifts, choroidal folds, disc swelling, cotton wool spots. There's a number of things that are going on when astronauts are in space for long periods of time. And again, it has to do with lack of gravity. And it has to do with, of course, we talk about glaucoma or low cerebral spinal fluid pressure, but in the absence of gravity, you can see where, again, it goes back to this physics equation, where now you've got maybe increased cerebral spinal fluid pressure in the presence of either normal or low intraocular pressure. And I think you can see the scenario of perhaps globe flattening, choroidal folds, hyperopic shifts, etc. So interesting, Joe and I just got, well, Joe, you weren't at the Optometric Glaucoma Society meeting. You were at Academy. We missed you at the OGS. One of our former students, Laura Padron, who was a student from IU, we really wanted to get her to do a residency with us, but she ended up deciding instead to go to Houston, where she did some PhD work, and she got her PhD. So she is now, I saw her at the Optometric Glaucoma Society meeting. She's working with a company in Houston, a NASA funded company where, guess what? They're trying to solve this problem of, what is it? Space flight associated neuroocular syndrome. So I thought that was interesting. So again, John Berdal also had done some work on this. And again, you can read all this in Glaucoma Today, which is readily accessible. He's done a lot of stuff that's really in a way that I think is easy to understand. And again, pretty much what we've just talked about, right? In the normal situation, you've got really a minimal translaminar pressure difference, but yet in glaucoma, low intraocular pressure, higher intraocular pressure, lower cerebral spinal fluid, large translaminar pressure difference, high intraocular pressure. And again, that's typical what we see in glaucoma. And so again, this is just kind of painting the picture of what happens. And I think for most of us, hopefully that makes sense. And so you kind of fast forward, right? With, can we get somebody on Mars? And so NASA really put out a petition to really a number of vision scientists trying to solve this problem. And John Berdal was really one of them. And so John came up with this idea. It's called the balance goggles. By the company he formed is called Equinox. So this looks almost like a pair of swim goggles, right? And so it's a pair of swim goggles that's hooked to a valve. And essentially what he's been able to show, do I have another picture of it? I guess I don't. What he's been able to show is he can dial in or change the pressure between, the back of the goggles and the corneal plane. So he can dial in, if you want a pressure lowering of 5 or 6, you got a pressure 28, we want to get a pressure down to 15 or 16. There's a little thing here where you can literally dial that in, and he's been able to show that you're able to lower intraocular pressure, not by a drop, not by a laser, not by a pill, not by a surgery, but by literally altering that atmospheric pressure between the goggle and the corneal surface. Now, obviously, this is like a swim goggle, and so the issue, of course, is if you jiggle it, does that the pressure gradient gets ruined. But the idea that perhaps this could be similar to maybe a CPAP, right? That maybe you don't need to wear it for 24 hours, or maybe you only wear it for a couple hours of the day, or whatever the case may be. But the idea is, again, he's been able to show that he can lower intraocular pressure with this method, right? And again, I think the original idea, not the original idea, but this was, working with NASA to try to solve the issue of prolonged space travel. But his really interest is in glaucoma. And he's got a couple studies, and this is, I think, maybe the first or second iteration of it. But I just thought, wow, that is so cool, right? And so this was John's grant trying to solve the problem, which I thought was really pretty interesting. And so again, whether it's intraocular pressure, perfusion pressure, cerebral spinal fluid pressure, I think at the end of the day, it probably boils down to this compromised autoregulation or dysregulation, the body's inability to kind of maintain this homeostasis. And again, whether it's, vascular factors like heart disease or high blood pressure, whether it's postural changes or atmospheric pressure or, sleep apnea, or, the list goes on that may kind of contribute to this. But I think you can see where that makes sense. So whether it's, again, autoregulation or vascular dysregulation leading to over-under pressure or whatever the case may be. But I think it's interesting. And I think it's what we probably all recognize and believe that right, there's probably more to this than just intraocular pressure. And so let's get back to Mrs. M. I told you I added another medication. We've got, in addition to latanoprost, we've got Alphagan. And again, I don't know that I did much, right? So her pressure were 12 before we added the Alphagan. It's 13 and 11 now. And this was a more recent visit this past year. And again, you kind of try to compare. Do I have a better slide of this? Kind of looking at really some of the numbers. Here we are in 2018, we were 83 and 123. You can kind of look here that, clearly she's a little bit thinner. The left eye inferior temporal really looks about the same. Who was I helping here? Was it her, or was it making me feel a little bit better? And did I really do anything? Interestingly, you see superiorly more change, 98 to 81. Certainly that's significant across the board here. But again, note that there's a large range of normal before we kind of hit this borderline yellow, right? And we'll kind of talk about that in a little bit as we kind of go along here as well. So she's been stable, good IOP, OCT done today, stable, but I guess they were poor quality scans. I didn't show those, but so I'm kind of maintaining her on latanoprost and Alphagan. I follow her at this point every 6 months. I do visual fields on one visit. I do an OCT on another visit, and that's kind of where I'm at. Does anybody have any questions or comments? Joe, do you want to chime in? I'm certainly welcome any criticisms or thoughts or ideas.
Well, no, not a criticism, but a question that came in quite some time ago, and now we've come back to her. A question was she on blood thinners?
She is not on blood thinners. She is on a high blood pressure medication, right? So it begs the question. So what role? She's in a nursing home, and as I said, thin, frail old lady. You could probably think she's got cold hands, and do you talk to her primary care physician and ask, is her blood pressure too low at night, right? I mean, those are the things that do you get involved to that extent? And I'm not ever sure, to be honest, how you answer that question. Do you tell her to just open a bag of Ruffles, potato chips before she goes to bed and just snack away? Some people ask that question, by the way, but yeah, I mean, whether it's a blood thinner, whether it's, blood pressure bottoming out when she sleeps, they're great questions to ask. And I don't really know the answer and what to do. Any comments?
This is Greg. Can you guys hear me? Can you hear me, Joe?
We can hear you, Greg.
All right. Yeah. So I've been listening, and thanks for letting me hop on a little bit late here, but I've been listening since almost the very beginning. A couple of comments that kind of tie a lot of this together, maybe with this blood thinner question is, you showed some really cool, great cases of optic disc hemorrhages from glaucoma. And I think one of the things I like to point out is, not all hemorrhages of the optic nerve are from glaucoma, but when we start thinking of these, which ones are the ones in that glaucoma prone zone, right? So we talk about inferior temporal, superior temporal is where we think. So you showed some great examples of where they should be in glaucoma. If they're kind of nasal and temporal, we have to start thinking maybe PVDs or something along that line, maybe a little hemorrhage from, being on a blood thinner or something along that line. And it was great that you showed that 84%. And the other day I was in reviewing that are missed. And I was in reviewing, my doc pulls me into to take a look at a glaucoma case. And we're looking at the left eye, and I said, let's jump over to the right eye. And we start looking at the optic nerve, big old Drance hemorrhage there. Yeah. And it was great because, almost, maybe this little embarrassing feeling or whatever. I say, hey, don't worry about it. 84% within the ocular hypertension treatment study were missed. And then the last comment that I'll make is, and then you can fill in anything that you need to fill in, is that I was listening to your polling questions earlier, and you said, referring to an ophthalmologist. I think, I want to pat ourselves on the back here about maybe putting a polling in there referring to an optometrist, right? I get a lot of referrals. I'm sure you do. I know I called Joe, and you has phoned a friend from time. So maybe refer to an optometrist.
Yeah, it's a good one and certainly appropriate.
Mark, what happened to her fields?
I think they're stable. I just haven't put them in. I mean, she gets fields, it's like usually once, twice a year. And I haven't.
This is interesting because she's had multiple disc hemorrhages at a normal intraocular pressure. At least I believe, or my what I see supports it with enhanced depth imaging, that there's a change in the laminar fibrosa that happens in these areas of disc hemorrhage, likely leading to that shearing of small capillaries in the blood supply, not so much as an ischemic phenomenon, but like a mechanical phenomenon. And it begs the question, do these people have connective tissue disorders, that they have weaker structures? And several years ago, there was a lot of work being done, and it seemed to have disappeared, about autoimmunity and autoimmune diseases in patients with normal tension glaucoma as well. So I think there is also another component that we might not be aware of yet.
Yeah, and certainly it's not all one thing or all another thing. It's in each patient, there may be something uniquely different. And certainly those are circumstances, whether it's autoimmune or, again, who knows what happens with sleep apnea and other things that contribute.
Hey, I got a question for you, Mark, and maybe we can help put this one to rest. You didn't use Alphagan for its neuroprotective property, did you?
So the answer is partially yes, right? I think there is, and the fact is nothing has been shown to be neuroprotective. I think, that's been looked at over and over. Interestingly, there is some data to show in normal tension glaucoma, again, out of that Bob Rich group in New York, they showed that patients on Alphagan compared to Trusopt, there was some better visual field preservation in the Alphagan group. And again, that was a study that was probably funded by Allergan. Who knows, right? So you never know. But I whether that's true or not true, I don't know. As I said, I felt like I needed to do something with consecutive disc hemorrhages and whether, again, didn't have any IOP lowering effect, but whether there in fact is visual field preservation effects, I don't know. It's a weak, right? It's a weak excuse for doing it. And again, Trusopt may have been, or dorzolamide may have been better. Obviously, I wouldn't want to put her on a beta blocker, which is an easy choice, accessibility. But so why? What do you think?
Well, no, I think, lowering the IOP with Alphagan is a great choice. I think it's going to help out I think it has some other potential positive side effects. I'm just not sure I'm sold on the true neuroprotection. I think there might be some other things out there helping to protect, but is it really preserving the nerve or the ganglion cell, I guess, or the axon? So,
in a case like this, Mark, you got a patient who's got a lower intraocular pressure to begin with. You got research from the normal tension study saying that, you can monitor these people. We're talking about translaminar pressure, cerebral spinal fluid pressure, migraine, vasospasms, sleep apnea, autoimmune factors, connective tissue disorders. But what it really comes down to in all these research patients is that N of 2. The N of 2 is you in the room and the patient in the room. And taking all of this noise and trying to make your best decision.
Correct. And by the way, and to Greg's point, I think any optometrist is just as good at making those decisions than a glaucoma specialist, as long as you have OCTs and their threshold visual fields and those type of things. I agree. We're not seeing 85 patients or 65 patients like our glaucoma guys. We have time to kind of dive in, spend a little time, weed out some of the issues, whether it's compliance or what have you. So I would definitely agree with that.
Mark, my final comment, and I'll let you move on, is, we always talk about, and Joe, you might be in that kind of when we talk about it is, we don't call it high tension glaucoma, right? So normal tension, glaucoma is glaucoma, like in my mind. However, there's this patient that is not within this statistics, right? They figured out, how did they find 10 to 21? They found that they did a whole bunch of pressure readings, found 16 to be the norm, went 2 standard deviations and said 10 to 21. And then when we start getting people around 21 and above, it starts going to glaucoma. Well, I think when we have normal tension and high pressure is that we see the same visual field defects. We're seeing the nerve die, so on and so forth. But I think the twist of why this makes it so confusing is, why is it happening at such a low pressure, which throws in the twist of now our wheels start to come off of our conventional thinking.
Yeah.
So, and it's just something that shouldn't be dying at a low pressure is.
Correct.
Right. So then what is it now? So,
yeah.
All right. I'm good.
So, and this is just kind of the more garden variety. This is where, and I've shown this case a number of times. This is the lady who has the subtle disc hemorrhage, shadow peripherally in her left eye, pressures of 16 and 17. She's been seen a number of times. And because she had this peripheral shadow, of course, the worry was, does she have a retinal tear, retinal detachment? And so we dilate her. But, again, everything's happening in the left eye, but yet you look at the right eye, and this is, maybe similar to the discussion we just had, right? If you weren't looking careful, you would maybe miss the fact that she's got a disc hemorrhage, and I think you can see she's got this nerve fiber layer defect that, and you take a step back, I think you can see it. Again, this just really shows where everything matches up very nicely. Subtle, ganglion cell defect. Here you got your visual field, and so again, is it normal tension? Does it matter? Would you treat? What would be your first line therapy? And again, so we already showed this. I'm not going to do that again.
Mark, what would be interesting would be to do a sister study to that missed disc hemorrhage. How many nerve fiber layer defects are missed on clinical examination?
Yeah.
I'm going to say it's going to be about 97%.
Yeah.
And that's why the camera is so important to us.
This is one of those, interesting cases where, when do you pull the trigger on glaucoma? And the idea is, what do you trust the available technology, whether it's a visual field or an OCT, or what do you put more trust in? This is a 73-year-old female who comes in for glaucoma suspect. She's had a past history of a single elevated episode where the pressure was a little bit higher in the right eye. On this particular visit, you can see her pressure is 21 and 19, average corneal thickness, a little bit of a cataract in both eyes, which may be kind of making the view in not maybe as good as we would like. You kind of wonder, speaking of disc hemorrhages, it's hard to tell, right? But so she's got small disc. We estimated the right eye to be about a 0.6, the left one not quite as big. And again, whether you call that a 3 and a 6, it's hard in this photograph, right? But again, you kind of do your OCT imaging, and here she is where everything looks pretty normal. Nothing jumps out on the deviation map. We've got, I think, a pretty nice RNFL thickness map. You look at your quadrants and clock hours, and everything looks pretty good. And you do your ganglion cell complex, and that seems to look pretty good. And here's your visual fields, which are normal. This is the right eye and the left eye. And so, this is the really prototypical glaucoma suspect, right? Where she had a suspicious disc and a borderline elevated intraocular pressure. You go through all your testing, and everything really looks normal. And so, what do you do in a setting like that? And even if you thought or believed that there was a visual field or disc hemorrhage there, at least in this setting, what do you do anything? And so, you talk to the patient, she's part of the plan, right? You educate, we're going to see it twice a year, and, you're suspicious, but we need to continue to watch you and follow you, right? But here's where it gets interesting, right? So, I'm kind of telling the story midway through. So if we go back 15 months, where again, her OCT was normal and her visual field was normal, and you kind of compare and look at those side by side. And again, these were pretty good OCT scans. You look in the right eye, and even though it looks green and normal, you can see that there's a change there, right? Almost a little over 15 to 20 microns, give or take, from one visit to the other. And again, in the presence of a normal visual field, does this represent progression? Do you trust or believe your OCT enough to say, boy, this, I know the visual field is normal, but you know what? I think this is progression. We need to treat you. And again, this goes back to 2012 and 2013. And I would venture to say, whether you believe it now, maybe back then we didn't, that's, maybe you would just, because it's green, you would pass it off as being normal, right? Because we're programmed to look green, yellow, red. And if it's green, all right, it's just normal. We'll continue to watch it in the presence of a normal field and normal intraocular pressure. And I would tell you that difference really is significant. And so again, you kind of compare and just kind of showing you so you can see a little bit better. And so really begs the question, how much change needs to occur on an OCT RNFL for it to be significant? Is it a 5 micron difference? Is it a 10 micron difference? Is it 20 or is it 25? How much change needs to occur on an OCT for it to be significant. And what I'm going to do, well, let's see where we go here. We'll get some responses. And I tried to show this a little bit differently, but let's see if it works this way. About 50% say it's about 10, and about a third of you say it's about 20 microns. A small percentage thinks that it's. So let's see. Hang on. So it doesn't show up here. Let me do this. Trying to see if there's a way that I can show this. Nope. Oh, and I lost it all. Well, most of you said between 10 and 20, and I would certainly agree with that. Again, 10 microns is significant. There we go. Let me see if I can show this. I'm trying to, not sure why. You guys aren't seeing it, right?
No.
All right, let's try. I was trying to alter my screen settings to see if it would show, and it doesn't. Nope. But as I said, the numbers were 10 to 20. And so again, just like a visual field, there's a large range of normal. You look at the average person, has an average RNFL thickness of about 107 microns. And you look at kind of where the tipping point is, where you go from this green to all of a sudden, boom, borderline. And that's at about 75 microns. So the point is there's a large range of normal that occurs before you get that tipping point where it goes from, green to yellow. And, the floor effect where it loses sensitivity really is about 40 to 50 microns. So the idea, much like a visual field, right? You can document change that's occurring while we're still within that normal range. And so that's why, again, looking at these individual, clock hours, the quadrant, it may be more like about 20 microns, but the individual clock hours, at 10 micron is significant. And again, it doesn't mean that that's the, all right, I'm going to treat point, but I think it's enough of a change that it should arouse suspicion and a red flag can go up. This was a paper out of the University of California in San Diego. Tammy Kwan, Felipe Medeiros, Bob Weinrab, and that group really kind of looked at how sensitive, or which is more sensitive in detecting progression in patients who were glaucoma suspects, I think. Detecting glaucoma. So these were glaucoma suspects. And so they followed a number of patients with visual fields and OCTs. And essentially, what they found was in about 35% of eyes, they were able to show change on the OCT 4 years before it showed up on a visual field. And in about 20% of eyes, under 20, 19%, they were able to show progression on the OCT 8 years before it showed up on a visual field. So again, their conclusion was that the OCT RNFL thickness is really very sensitive and capable of picking up subtle change, right? And so again, we look at her, we didn't pull the trigger, even though we were detecting that there was change present. Again, in the presence of a normal visual field. And so you kind of look and see what happens to her the next year, right? You've got on the deviation map a change. You've got on the ganglion cell complex, she's got a defect, and we were able to, I won't spend a lot of time, but you can kind of see inferior longitudinally it going down, and she ultimately ends up, here she is, 3 or 4 years later, she's got a superior nasal defect that, our clinical suspicion proved true, initial progression in a normal rate. And of course, in her case now, yes, she's got it. What is the rate of progression, et cetera, et cetera? Well, she ends up developing a cataract. Within the last year, she ended up having cataract surgery and a couple eye stents put in, which, again, the idea that we were able to document change 3 or 4 years before it ended up showing up on a visual field. And so really the question, do you trust your OCT? Is that change significant? And again, I think back then we probably didn't have the trust and confidence in it that we do really today. And we'll show another case where there was change under my nose that I didn't be able to pick up either. And so
Hey,
again,
Mark,
this
go back one slide,
this
because
one?
you said it and I want to echo it. And I think it's so important. You said it, but it was kind of quickly. And you said, like, say 15 to 20 microns in the quadrant, maybe point that out on that OCT.
So yeah, this is your
but-
kind of quadrants. And so, with the Cirrus, you've got individual clock hours. With the OptiView, you've got, I think, literally like 2 clock hours that are put together. So, each OCT software is going to be different. This is the quadrants, which again, not quite as sensitive as individual clock hours, but again, a combination of a couple of them, I think, would be significant. How do you look at it on the OptiView, Greg?
Well, I'm just saying, it doesn't matter what instrument it's, but they kind of do the same thing. They do quadrants and they get down into the clock hours. But what you said is, 20 microns in the quadrants, so 15 to 20 in the quadrants. But if you get down in those clock hours, I think it's, 10 is enough to start scratching your head and turning some rocks over. The only other caveat I'll throw out there is there's a lot of things happening in these glaucoma patients, epiretinal membranes, PVDs, that can change that. And that, and we just got to make sure that it's true atrophy. It's apples to apples, that it's, if it's atrophy not being influenced by the posterior vitreous or an epiretinal membrane.
And that's the art of being able to follow glaucoma and having technology. And I always say that this is really the fun of it, when you've got the technology to be able to look at these people. And again, an ophthalmologist or glaucoma specialist doesn't have any more or better information than what you do. Here's a patient that you've been following, you've established a relationship. At some point she turns the corner, right? You begin treatment. I don't think we've lost anything. And I don't think there's a fear of malpractice or gosh, am I going to get sued? Or, I think, you do the best you can. You have time. Clearly in this instance, we were able to show change, but, didn't really believe it, didn't really trust it. She turns the corner. Now you treat her, and she's, functionally, from a quality of life perspective, there's really nothing that's different, right? Binocularly, she's still able to drive a car. She's still able to do the things she likes to do. And yeah, you want to detect change or treat them before they get to that point. But we know there's a lot of factors, as we've talked about, that goes into that. And in this case, it just happens. So again, that's part of the nuance, right? The next time it happens, we'll catch it, and we won't allow that to happen, hopefully. This is Peter Chang's algorithm. So again, detecting glaucoma progression using the OCT. So again, RNFL thinning on OCT, patient able to do a reliable visual field. So yes, if the thinning is greater than 10 microns, and of course, do they have a visual field defect? Yeah, pretty clear, right? Glaucoma has progressed. If the change is not more than 5, but yet, not more than 5 in a normal field, progression is not confirmed. Repeat studies at appropriate intervals. If it's, 5 to 10 and you get a visual field defect, then right, it's really pretty simple when you look at it algorithmically, as Peter kind of points out. And I think it's a good simplification way of looking at it. So this is our Arturo. He's a 50-year-old Argentinian male. This is an interesting one, right? And it's one of those that if I had to do it over again, I probably would. But let's kind of see where this takes us. I see him in 2012. He's got a history of having had RK done. He's 20/20, but you look, he's a +4 with a diopter and a half of hyperopic astigmatism. His pressure is 32/18, average corneal thickness, but again, right, he's had a history of RK, so you don't know what role that plays. And you look at the nerve, right? Clearly the eye that's got the higher pressure has a bigger cup. The eye with the lower pressure has a smaller cup. I don't know if the nerve looks a little bit bigger. We can look at that when we do an OCT, which, by the way, is completely normal. And so again, nice scan. You look at thickness maps. It's nice and thick and robust. Everything looks pretty good. Note that the disc area in the right is bigger than the disc area in the left. So the adage, big nerves can have big cups. And so sometimes when you see cup to disc asymmetry, it's important to try to look and see, well, is the nerve in this eye bigger than the nerve in that eye? And you typically feel better when you can look at it and say, well, I think the nerve is bigger. And again, because it's a bigger nerve, does that explain why the cup is bigger? And again, OCT allows us to do that, I think, better than we were able to do just based on our regular clinical exam. Here's our ganglion cell complex, which is normal. And so it kind of goes back to one of the questions we talked about from the beginning, right? Obviously, he needs a visual field. And I tell you that we do all our visual fields undilated. And so now that he's dilated, would you treat Arturo on this initial visit with a pressure of 32 and 18 in the presence of a normal OCT? And so, this is an interesting one, right? Because we all have kind of a threshold where, all right, 24, 25, let me bring them back. But 30, boy, I think for most people, 30 makes your toes tingle a little bit, and it makes you a little bit worried and concerned. And so, this is a good one. So what would you guys do, Greg or Joe? Pressure of 31 or 30 and a normal OCT, and would you treat on this visit? Do you say, let me bring them back in a week or two? How do you handle that?
I'm probably going to bring him back, get more data, more pressures.
Yeah.
I'm going to get visual field. You've got pachymetry, gonioscopy.
Uh-huh.
You've got disc photos. These are all things that we need to do. And I've always said glaucoma is a disease of months and years, not days and weeks.
But is there a pressure where you say, gosh, that's just too high for my comfort level? I would worry, what if he doesn't come back? Or what if he, we know that there's a risk of central retinal vein occlusion over 30. What if he comes back and now he's got a CRVO and I could have prevented it? Do you ever,
No, I don't buy the CRVO issue. I've seen a number of CRVOs in glaucoma patients because there's comorbidities.
Yeah.
But in every one of those CRVO patients that I've seen, Mark, they've been on treatment with well-controlled pressures.
Yeah.
I've seen pressures 50, 60, 70 and never saw a vein occlusion. So I'm
what
gonna,
about it
go
if
ahead.
the pressure's 40?
If the pressure is 40, I probably would
I would
treat.
35. I would.
Well, you see here, here the magic number that I give people if they're looking for a number, I say 34, and here's why. In the OATS study, a pressure of 34 disqualified them from enrollment into the study, and the reason was there's no science behind it, but it was consensus by a lot of smart people in glaucoma who are very experienced in glaucoma. They realized that once you go above pressure of 35, there's a 50% chance that person would be randomized to observation without treatment. And these thought leaders more or less felt uncomfortable with it. So they cut it off at 34. So if anybody's looking for a magic number, that had some consensus to it, 34 in the OATS study. They wouldn't let people be in the OATS study with that pressure because of the 50% risk of being just observed. They didn't feel comfortable doing it.
60% of you said you would treat. 40% of you said you would not treat. So, interesting. Some people, again, that pressure 30 or 31 is kind of a little concerning. So this is what I did.
I think, Mark, to kind of give some comfort is that you gave a lot of information to showing that there was not a lot of damage, or there wasn't any damage. And so with that being said, I think, that gives us time to take a breath, take a step back. Did you say anything going on gonioscopy there? Did you say what's going on?
Open angle, wide open.
Yeah. Like equal trabecular meshwork, pigment, all that stuff is.
Yep.
Yeah. So, I think it gives us time to figure out, is it just a bad pressure day or so on and so forth. Now I wouldn't let them come back in a year. I think we have, maybe as short as 2 weeks and as long as 6 weeks to bring them back and do some further testing on them and go from there. But, the nice thing is you showed us all kinds of normal stuff. And I'm like Joe, I'm not big into the CRVO unless, it's an end stage glaucoma and everything's kind of brittle back there. And maybe you could shift things and close it, but you just showed us everything was healthy.
So this is what I did. Bring him back, and interesting, he comes back a month later and now the pressures are 24 and 25. And so how do you account for that difference? Is it operator error? Is it, we have students, so did the students press too hard? Is it just the fact that he's at RK and who knows what role that plays? And I don't do corneal hysteresis, so
Mark, I do want to take kind of exception to that, because I would assert I probably trained those students that were there.
This was in Indiana, Joe. So you don't have to worry.
I've always said that my students were very good. They were almost always within 10 or 15 millimeters of my pressure.
Yeah. But, I think it does illustrate the importance of baseline, right? So if you would have put him on a prostaglandin, he's down to 22. I mean, you're like, oh, wow, this prostaglandin really worked. But, again, you look at this not diurnal, just this intravisit, variation in pressure, whether it's real or not real, was the 32 real or not real? I'm not really sure. This was the first visual field. Remember, the right eye that had, the larger nerve, higher pressure. This is normal. This is the left eye. First time field, this goes away on a repeat field, just so you know. So again, right eye, pretty reliable. Left eye. Here he is a year or so later, and things look pretty good. And so the interesting thing with him is, right, do you treat him? Do you not treat him? And again, what is the basis? He's in his early 50s. When you look at, ocular hypertension, I think, really there's nothing more that's, speaks about probability. We've got so much data from the OAT study that help us make, I think, really well-educated decision. The idea that, you got an ace, the probability that, the next card is going to be a face card, right, is really pretty good. And we would bet on that all day long. And so it's interesting. I want to kind of go through quickly some of the data from the OATs, and in particular, the 20-year data has actually just been released this past spring. So, as you know, long-term randomized multi-center trial, 1,500 patients followed for 5 years, seen twice a year. We've kind of talked a little bit about that. So, Joe, they said 32. So whether it's 32 or 34, I don't know. They ended up with 1,600 people. Remember, the goal was a reduction of 20% or an IOP less than 24. Again, just because really the question was, does treatment make a difference? Can we reduce that risk of progression or conversion from ocular hypertension to primary open angle glaucoma? And so we learned, right, treatment reduced the chance of developing glaucoma by 50%. You look at the observation group about 9.5%, the treatment group about 4%. And so they concluded that meds are effective in delaying or preventing the onset of glaucoma. In the African-American population, that number was double. Instead of 9, it was over 16% in the untreated group, and the treatment group was 8%. So again, treatment lowered the risk of glaucoma by 50%. And these are versus the study that really put corneal thickness on the map, right? That eyes that had thinner corneas, their risk could be as greater than 3 times greater risk of developing glaucoma than eyes that had thick corneas. And in fact, if you had a really thin cornea and a baseline pressure of 25, your risk could be as high as 36%. You combine that with maybe even a thin cornea and a smaller cup to disc ratio, your risk was pretty significant. This is the idea that really a picture is worth 1,000 words, right? So if you look at thin cornea on the left and thick cornea on the right, and again, looking at various IOP levels, even a thin cornea with the pressure 23, 24, your risk, I think, was pretty considerable compared to, again, higher pressure and thin cornea, you're looking at a significant risk. And then across the board, you look at these thick corneas. And it was interesting, Joe, and Greg was there in the OGIS meeting. We had a discussion on this, and the patient who comes in with a pressure of 25 and a 600, or 650 micron cornea, the conclusion was that pressure is just an artifact, because that patient doesn't have glaucoma. They're not even a glaucoma suspect. The pressure that you're measuring is just not real. And again, it's just predicated on the idea of the fact that it's just a thick cornea. And so again, if you get a thick cornea really across the board, even a thick cornea and a high pressure, your 5-year risk is still relatively low. And I think that's I think that's pretty powerful, right? Again, even you look at larger cup to disc ratios across the board, thick cornea, again, pressure is, I don't want to say it's meaningless. It's just not as significant as somebody who has a very thin cornea. And so thin cornea is older age, larger cup to disc ratio, higher IOP, again, being significant risk factors for glaucoma. And again, some people use the risk calculator and the idea that, if you have a low risk, lower than 5, then maybe you recommend observation. If it's that 5 to 15%, you discuss with the patient, you talk about what they want to do. And over 15% risk is maybe considered high enough that you should encourage treatment. I typically, I don't use a risk calculator, but I do kind of in my mind, again, putting all that information together, kind of gauge what I think that risk is and make recommendations based on that. And so this was a couple of years ago at OAT study, right? May Gordon, presented the 20-year data on the ocular hypertensive treatment study. And so they had really a 66% retention rate from the beginning when they started 20 years ago. And again, 2/3, whether the medical group or the observation group, they had known IOP data on 75% of them. And so across the board, 30% of people develop glaucoma. And when you looked at that, 220 in the medicine group, 266% in the observation group. When they developed glaucoma, about 2/3, 64%, when they developed it, they only developed it in one eye. And so one of their conclusions was that glaucoma is largely a unilateral disease, but again, maybe that's because they caught it early, and once they were treated, they didn't really develop it in the other eye because it was treated. 72%, so almost 3/4 in the initial observation group ended up being on medication anyway. Again, we didn't talk about this, but 1/3 of them, 36%, when they developed glaucoma, they developed it in both eyes. And so about a 30% developed glaucoma over a 20-year period. Various risk factors may increase that percentage. And again, the things that we know, older age, thinner cornea, higher IOP. When it does convert, it's largely a unilateral disease. Most patients with ocular hypertension over the course of their lifetime will end up with treatment. Then I think this is interesting, right? The risk of converting to glaucoma is about the same as dying. In somebody who's 70 years old, whether you treat them or not treated, you again, not that we want to observe them or we look at risk factors, but I thought that was one of the interesting conclusions that they made. Any comments, Joe and Greg, regarding the OATS and 20-year data?
I think when you point out that it was generally a unilateral disease, I think it comes down to the surveillance. I mean, how close these patients were being watched, and as soon as they find there's been a conversion, well, they're taken out and everything is being treated. So maybe not unilateral, but I would accept the concept of asymmetric disease.
Correct. Well, every new beginning comes from some other beginning's end. So I didn't make that up either, by the way. But again, to your point, right? These were people who were in a clinical study and they were followed. So we know that well, POAG starts from ocular hypertension one way or the other. And it's just that, they weren't followed, and it was not caught early enough by the time they come in to see you. So yes, to your point, right? These were people who it was caught, they were treated, and the other eye never really developed it. Had they not been treated, I think we recognize they would have probably developed it in both eyes if they would have gone long enough. Greg, any comments?
Yeah, I mean, Mark, my only comment was, and I was there talking about it, and it goes back to one of the Joe knows my soapbox with PAC imagery, is that, thick cornea is lower risk, thick cornea is higher risk. Take that into account, but don't adjust pressures up and down based on that. So there was no discussion on, that was a 24, so that must have been a 26, or no, that was a 23. What I want to make sure this audience knows tonight is don't adjust IOPs up and down.
I agree. Let me just finish quickly with Arturo, and we'll finish up here. I think we're not going to have time for any more, but so this is one of those situations where he would kind of vacillate. Sometimes the pressure was a little higher. Here he is at 27 and 22. Sometimes he would be down as low as 18. So he really had this variable, pressure reading. He was good about coming in. He didn't always have insurance coverage. So in terms of wanting to do visual fields and testing as often as we wanted to, we really weren't able to do it, but we did it enough. And here's kind of one of those examples, right? Again, I'm going to draw your attention to the thickness map, how thick he is. You can see he's still in the green. I'm going to highlight for you, this was at both visits in 2012 and 2013, how thick, his superior, quadrant is, which, just keep that in mind, right? Here's his visual fields. They're completely normal. I follow him. Here's a visit. He's 19. And again, we repeat the OCT, and I remember looking at this OCT. And again, remember, this is the 19 visit, saying, everything looks normal. But the fact is, when you look at it, he's not normal. He's not normal. Look at the change, especially in that superior temporal quadrant, superior quadrant, that at the time I completely missed. I'm looking at colors and the fact that he's still in the green and his visual field is normal and his pressure is a little bit better. Let me just continue to follow you, but yet clearly you're seeing thinning of his RNFL. And here he is on one of those visits 4 months later. Now the pressure is 29, and he's got, just like the other lady, he ends up with a visual field defect, and guess what? He's on treatment. So you kind of watch him, right? 12, 13, 14, and there's a couple other visits there. Here he is, 16, finally develops it. And so, yeah, OCT probably normal. Clearly he wasn't normal. And it was just, as I had started to get more experience and started to really look more critically, you realize that there was change occurring while the patient was in that normal range that I just, wasn't savvy enough or smart enough to really recognize. But I do now.
So here would be another comment, Mark.
Yep.
In the Altoona area where I live, it's a big railroad area. The railroads were big, and they still are in this, to the big part of the economy. And about 1990 to about 2002, one of the railroad companies were paying for RK.
Yeah.
And the surgeon in the area here, people were just lining up. I mean, there, 10, 20 patients a day. So, I mean, I see a lot of it in the area because the railroader after railroader after railroad was just going in and getting this done. And so the question I would have is, were there equal cuts between the right and left eye? And the eye that I would be more concerned about with your pressure, because I see a ton of people, we have to deal with them now because they form cataracts. They shift because it's a corneal weakening procedure. They're going to be hyperopic, myopic after they put the implant in. You have to kind of coach them for 6 weeks. So my concern in this whole case is, where I'm going with this is, watch that left eye because it could be underestimating the IOP. We're assuming that all corneas are created equal. They put the same amount of cuts in, which might not be the same. It could be an 8 incision or a 10 incision. I think that left eye pressure could be higher than it really is.
Yeah, could be. Yeah.
Just FYI. I mean, I have a ton of experience, unfortunately, in RK.
Yeah, it's, as I said, I called it the clarity of retrospect. I look back and I'm like, what was I doing? Here's a young guy who's vacillating in pressures anywhere between 30 and 20. And why, what are you waiting for, right? His risk is pretty high. And you try to be a cowboy and, well, let's just kind of watch this. And as it turns out, he gets worse. So here's one of those that I again, especially given the circumstance of the RK, I wish I would have treated him earlier. But again, that's what we do. We live and learn.
Oh yeah, Mark, we all have the woulda, shoulda, couldas, and hopefully it really hasn't been too deleterious to any of our patients. But you use the phrase, watch them, and that is very important. We have to watch because everybody's a little bit different. You talked about 600 cornea and ocular hypertension. I've seen, I've had numerous patients in the low 30s with a above 600 cornea, and nothing happens.
Yeah.
I mean, just nothing happens. And then I can think back to a patient that I actually inherited from somebody at your place, Rich Parrish. Mm-hmm. And Rich Parrish had diagnosed glaucoma in this woman. And I looked at everything and I wholeheartedly agreed. She had, she had a small knot. She had a corresponding visual field defect. Everything was just, consistent with glaucoma. But she was young. She was maybe 41, which is a little bit, and she didn't even look 41, but she was on the young side. had glaucoma for several years. At that point, had a 650 cornea and a peak pressure of 23.
Yeah.
And this, young woman developed glaucoma
Wow.
in one eye.
Yep. I've got one of those too, by the way.
And Mark, another
maybe she
guy
came
just sit here
back.
thinking about RK, and I have probably 3 patients in the office that have glasses that are a diopter difference from their AM to PM
Yeah,
because
I had
they're
one yesterday, Greg, exactly that. He wears a pair of glasses in the day, and then at night he puts on a different pair of glasses.
Yeah. So, I mean, what's that telling you about the cornea, right? And diurnal fluctuations and so on and so forth. So not every RK patient is going to respond the same way. So
Any final comments that you want to make, Mark, or how do you
Oh,
want to land
we had
this?
130 people on here. Let me stop my share and get back to you guys. It was fun. It's great when you guys are there and we can kind of chat about some of these things. I wish we could open it up, and it's fun to talk about glaucoma cases and get people's perspective and whatnot. So I love doing it.
And I hope you didn't mind us getting involved, the audience mind getting us involved, but I think we all agree that when we're speaking to a computer, it's not really quite the same. And to hear somebody else on the other end responding to you is always very enjoyable.
Yeah. Well, nobody wants to hear a gas bag for 2 hours anyway, so it's always good to have interaction.
So thanks, Mark. That was a great
Thank you, guys.
presentation on the pressures on managing challenging cases in glaucoma. I really appreciate when I look at your title, I think I know what it's going to be about, and it might be a little bit different, but it just I think it's just wonderful how you create a lecture based upon science and your experience. And I mean, there's some of the best lectures really I've ever heard. So I really appreciate that.
Appreciate
Mark.